Episode 18, hip pain, back pain, or something more. Welcome to Sports Medicine Case Studies, where I review published case studies in sports medicine for learners. Today's case, 16-year-old male presents to a chiropractic clinic with intermittent right-sided hip and lower back pain with insidious onset over a year and a half. There was no recent trauma described. The pain was described as 8 out of 10, worst in the morning, and aggravated by transitions from sitting, walking, bending forward, and lying on his right side. There was no pain with coughing, sneezing, or bearing down. And the patient denied any ominous findings such as unexplained weight loss, night pain, no fever, no night sweats, no blood loss, or bowel or bladder dysfunction. The patient's past history included a fall onto his tailbone from a 6-foot wall 4 years prior to presentation, which was treated conservatively. His family history is notable for a mother who had a history of bilateral slipped capital femoral epiphysis, which were treated surgically when she was an adolescent. 7 months earlier to this presentation, the patient presented to his family physician who ordered imaging of the hip, an AP and frog leg lateral radiograph. The radiologist report noted minimal widening of the right femoral epiphyseal plate, but then concluded the films were unremarkable. The ultimate diagnosis from that visit was hip tendinitis. On examination, he had a slightly antalgic gait with a lean to the left. Range of motion in the right hip was restricted and painful, especially with passive flexion and internal rotation. Okay, my differential diagnosis, obviously we have hip tendinitis from the original evaluation. Given the history, slipped capital femoral epiphysis, which I'm going to abbreviate to SCIFI, lumbar spine pathology, and potentially a GI hernia. I want to recognize the authors. It's Dr. Emary from a published case report from the Canadian Chiropractic Association. I picked this one because it's very typical for the diagnosis. I'm Scott Hull, a primary care sports medicine physician, and I'm studying for my sports medicine recertification exam in 2026 and hope you'll join me on the journey. This podcast is for educational purposes only. The chiropractor took new AP and frog leg lateral radiographs. Using Klein's line, which is a line drawn from the superior border of the femoral neck, the chiropractor identified posterior medial displacement of the capital femoral epiphysis. The slip was more pronounced on the frog leg view. The patient was referred back to his primary care physician with a diagnosis of SCIFI and a recommendation for orthopedic consultation. The orthopedic surgeon ordered confirmatory radiographs, and once the diagnosis was confirmed of a SCIFI, the patient was successfully treated with in situ pinning. Key takeaways from this case. Slipped capital femoral epiphysis, or SCIFI, is a hip disorder in which the femoral head, the epiphysis, displaces posteriorly and inferiorly relative to the femoral neck, which is the metaphysis of the bone. The growth plate is commonly weakened, and it is the most common hip disorder in adolescents, typically occurring between ages 8 and 16 years during periods of rapid growth. The condition results from weakening of the proximal femoral physes, with mechanical stress from obesity and metabolic conditions such as hypothyroidism contributing to the slip. SCIFI is bilateral in many cases. Patients commonly present with hip pain, though knee pain alone occurs in almost 1 out of 4 cases. The physical examination typically reveals limited internal rotation, obligatory external rotation with passive hip flexion on exam, which is known as Dremen sign, and an antalgic gait. SCIFI is classified as stable when the patient can bear weight with or without crutches, or unstable where weight bearing is not possible. The diagnosis is confirmed by hip radiographs, including AP and frog leg lateral views. Early diagnosis is critical because delayed recognition increases the risk of serious complications, including avascular necrosis, chondrolysis, and femoral acetabular impingement. Treatment is surgical, with in situ screw fixation being the standard approach for stable SCIFI. I want to comment on radiographic findings, and there have been several studies looking at different evaluation methods. Bilateral hip radiography with AP pelvis and frog leg lateral views is the gold standard for diagnosing SCIFI and should be obtained in all children and adolescents with a new limp or hip, groin, thigh, or even knee pain. For unstable SCIFI, one can obtain a cross-stable lateral view to replace the frog leg view to avoid further displacement. Klein's line is most commonly used diagnostic finding on AP radiographs. Klein's line is drawn from the superior border of the femoral neck. In SCIFI, this line fails to intersect with the femoral head epiphysis. The classic Klein's line has limited sensitivity, and one reference reported identification of only about 40% of SCIFI cases, particularly missing mild slips. The frog leg lateral view is more sensitive than the AP view, identifying nearly all SCIFI cases in comparative studies. Advanced imaging is recommended when there are equivocal radiographic findings with high clinical suspicion or to assess blood supply to the femoral head with an unstable SCIFI. Okay, board questions. Here you go. Number 1, 13-year-old obese male presents with a 3-week history of right knee pain and an antalgic gait. He denies any trauma. Examination of the knee reveals no effusion, full motion, and negative ligamentous testing. Which of the following is the most appropriate next step? A, MRI of the right knee. B, physical therapy referral for patellofemoral syndrome. C, hip examination with AP pelvis and frog leg lateral radiographs. D, a trial of anti-inflammatories and activity modification. Answer, C, complete the hip exam and obtain imaging. Up to a quarter of patients with SCIFI may present with knee or distal thigh pain as their primary complaint due to referred pain along the obturator nerve distribution. In any adolescent with knee pain, particularly if obese and with an antalgic gait, a thorough hip examination, bilateral hip radiographs are essential to evaluate for SCIFI before attributing symptoms to the knee. Okay, question 2. Which of the following radiographic findings is most sensitive for detecting a mild SCIFI? A, widening of the physes on the AP view. B, failure of Klein's line to intersect the femoral epiphysis on AP view. C, failure of Klein's line to intersect with the femoral epiphysis on frog leg lateral view. D, decreased height of the femoral epiphysis on AP view. And E, sclerosis of the femoral neck on AP view. The answer is C. The frog leg lateral view is more sensitive than the AP view for detecting SCIFI, identifying almost all cases in comparative studies. Question 3. 14-year-old female with a body mass index of 32 kilograms per meter squared presents with acute onset of severe left hip pain after jumping during basketball game. She is unable to bear weight. Radiographs confirm an acute slipped capital femoral epiphysis. Which of the following is the most serious complication associated with this presentation? A, femoral acetabular impingement. B, labral tear. C, avascular necrosis of the femoral head. D, chondrolysis. E, leg length discrepancy. Answer C. Avascular necrosis is the most devastating complication of SCIFI and is most commonly associated with unstable or acute slips. During the acute slip, the lateral epiphyseal vessels can be disrupted, compromising blood supply to the femoral head. Patients with AVN exhibit rapid osteoarthritic deterioration and often require total hip replacement even at an early age. Question 4. 12-year-old male is diagnosed with a stable mild SCIFI of the right hip. Which of the following is the most appropriate initial management? A, non-weight bearing with crutches and observation. B, physical therapy for hip strengthening. C, in situ percutaneous screw fixation. D, open reduction with internal fixation. And E, intertrochanteric osteotomy. Answer C. In situ percutaneous screw fixation is the standard treatment for stable SCIFI regardless of the severity. The goal is to prevent further slippage and promote physeal closure while avoiding complications such as avascular necrosis. Non-operative management is not appropriate as it allows for continued slippage and deformity. Open reduction and osteotomy are reserved for specific situations such as severe chronic slips or deformity correction. Question 5. A 15-year-old male presents with an 8-month history of progressive right groin pain. Examination reveals limited internal rotation of the right hip with obligatory external rotation during passive hip flexion on exam. Radiographs reveal a chronic SCIFI. Laboratory evaluation reveals a TSH of 85 with the normal range being 0.5 to 4.5 and a free T4 of 0.3. Which of the following statements regarding this patient's management is most accurate? A. Hormone replacement therapy alone will lead to physeal fusion and symptom resolution. B. Surgical fixation should be performed before initiating thyroid hormone replacement. C. Thyroid hormone replacement should be initiated and surgery deferred until the patient is euthyroid. D. The endocrine abnormality is unrelated to the SCIFI. And E. Bilateral prophylactic pinning is contraindicated in patients with endocrinopathies. The answer is B. SCIFI is associated with endocrine disorders including hypothyroidism, growth hormone deficiency, and hypogonadism. While thyroid hormone replacement can promote physeal fusion, initiating hormone therapy before surgical stabilization may cause fusion in a displaced position, hindering optimal reduction and predisposing to degenerative arthritis. Surgical fixation should be performed first, followed by treatment of the underlying endocrinopathy. Question 6. Which of the following physical examination findings is most characteristic of SCIFI? A. Positive Trendelenburg sign with hip adductor weakness. B. Obligatory external rotation of the hip during passive flexion. C. Pain with resisted hip flexion. D. Decreased hip extension with a positive Thomas test. E. Clicking or catching with hip flexion and internal rotation. The answer is B. Dremen sign. Obligatory external rotation of the hip during passive flexion is the most characteristic physical examination finding described in the literature for SCIFI. This because the posterior displaced epiphysis mechanically blocks internal rotation and forces the femur into external rotation as the hip is flexed. While other findings such as limited internal rotation and an antalgic gait may be present, the Dremen sign is pathognomonic for SCIFI. Thank you.